A very good morning. Myself Dr. Agila, Professor from Department of Periodontology, Chetna Dental College and Research Institute. The topic for today's discussion will be on periodontal. So periodontal disease is one of the commonest dental disease apart from dental caries. So there are various factors which can modify periodontitis, which include environmental factors like smoking, the physical, social, host responses as well as stress. The systemic diseases. There are various systemic disorders which can contribute to periodontitis. However, the treatment aspects, the alterations clinically can help us to stop. There are various evidences that are associated with the correlating the systemic diseases that are associated with periodontitis. Periodontal medicine focuses on how periodontal infection can affect the systemic diseases. The bacterial infection that is present in the oral cavity, periodontal infection is one. So the periodontal medicine concept was first introduced by Offenbacher. It is a rapidly emerging branch of periodontology focusing on the wealth of new data, establishing a strong relationship between periodontal health or disease and systemic health. So what are the organs that can be affected by periodontitis? Cardiovascular system, cerebrovascular system, endocrine, reproductive system. So what is the pathobiology of periodontitis? The non-specific plaque hypothesis plays an important role here. The gram-negative microorganisms, especially the red complex like the Porphyromonas gingivalis, Tannerella forsythia and Treponema denticola. Apart from this, the host susceptibility responses and the treatment outcomes may also affect the progression of the disease. It was William Hunter who described about the focal infection, where he told that the oral microorganisms play an important role in caries, pulpal necrosis and periapical abscesses, gingivitis and periodontitis as a foci of infection. So there is always a concept of low sub-infection. In 1940s and 1950s, considering this, they done a widespread extraction even if there was a caries. But there was a very little scientific evidence to get proved. So they were unable to explain the correlation between the periodontal infection or any dental infection associated with systemic disease. So the only solution was just tooth removal. The intervention of tooth extraction often had no effect on the systemic conditions for which the relief. The subgingival environment, there is persistent gram-negative bacterial challenge to the host, the lipopolysaccharides which are released by the endotoxins, the total surface area of the pocket epithelium is almost in the palm of a hand, that is bacteremias. So what is the correlation of periodontitis and the coronary heart disease? It is basically atherosclerosis which causes death. The infections are also one of the reasons, like how it leads to sequence of events. So atherosclerosis is basically an inflammatory disease. The periodontal infection causes progression of atherosclerosis. Periodontitis and atherosclerosis forms a complex which are responsible for etiological factors. Smoking may share the risk factor. So the atherogenesis and thrombogenesis, which causes increased viscosity, which causes increase in fibrinogen and increased fibrin, may lead to heart disease. So this flow chart explains us how a chronic heart disease causes atherosclerosis, thereby causing narrowing of coronary arteries, which leads to myocardial ischemia followed by angina and myocardial infarction. Whereas the acute coronary heart disease, which causes thromboembolism followed by occlusion of coronary arteries leading to myocardial ischemia followed by angina and infarction. So there is increase in the plasma fibrinogen, plasma lipoproteins like LDL and VLDL, white blood cell count, which cause viscosity. So this systemic infections induce a hypercoagulable state, increased blood viscosity, the WBCs and fibrinogen levels are increased, thereby contributing to increase in thrombus risk of heart disease. So this systemic or periodontal infection causes increase. This is a flow chart which explains, and thereby causing bacteremia. 8% of infective endocarditis causes dental procedure. The American Heart Association has told that the best possible oral health to reduce potential sources of bacterial seeding is through infective prophylaxis, antibiotic prophylaxis. The periodontium serves as a reservoir of gram-negative organisms. In thrombogenesis, there is platelet aggregation. The Streptococcus sanguis, Porphyromonas gingivalis, there is platelet aggregation associated protein. The periodontitis associated bacteremia with certain strains of Streptococcus sanguis and Porphyromonas gingivalis may promote acute thromboembolic events circulating platelets, thereby leading to atherosclerosis where there is focal thickening, circulating monocytes adhere. The adhesion molecules like intercellular adhesion molecule 1, endothelial leukocyte adhesion molecule 1, vascular cell adhesion molecule 1. So these are upregulated by the bacterial lipopolysaccharides, prostaglandins and the monocytes release foam cells, thereby leading to atheromatous plaques. The monocyte macrophage forms a complex. These atheromatous lesions are also through by the interleukin 1, tumor necrosis factor alpha and PGE2 propagate. Lumen narrows, thereby there is compromise in the blood flow. Where the plaque ruptures, the platelet and fibrin accumulation that recruits the blood vessels. So in this picture you can see that how the foam causes and the atheromatous plaque thick vessel wall. So what is the role of periodontal disease here? The gram-negative bacteria and the lipopolysaccharides causes intravascular coagulation. The periodontitis causes increased risk for thickening of the walls of the major coronary arteries. There is low-level bacteremia, atherogenic changes and possible thromboembolism. The hyperinflammatory monocyte macrophage phenotype. Monocytes or macrophages causes increased levels of pro-inflammatory mediators in response to bacterial lipopolysaccharide, propagation of atheromatous lesions, periodontal destruction in the presence of organisms. So, to summarize, you can see that periodontal infection can lead to gram-negative bacteremia, the release of lipopolysaccharides, endothelial damage which causes platelet addition or aggregation, monocyte infiltration or proliferation. Thereby, there is a thrombus formation leading to atheroma formation, vessel wall folic events. So, the macrophage phenotype gets altered. Periodontal pathogens along with periodontitis causes chronic bacterial challenge, release of pro-inflammatory cytokines which causes acute phase reactants. Thereby, vascular effects are triggered which causes hypercoagulability, atheroma formation and thromboembolism. The C-reactive protein is an acute phase protein. It is mainly processed in the liver, inflammatory marker. The CRPs are the monocytes acts as a tissue factor, stimulates the pathway, increases the blood coagulability. The CRP augment cascade. Moving on to periodontal disease and stroke. The systemic bacterial or viral infection can be the reason. The recent infections are independent. However, hypertension, history of previous stroke, diabetes, smoking may also contribute. The greater ischemia, severe post-ischemic neurologic defect. So here the plasma fibrin is higher in both serum. Here also there is a thromboembolic events. The periodontal infection causes persistent bacterial challenge to arterial endothelium. The monocyte or macrophage driven inflammatory process, atheromatosis and narrowing of the vessel lumen. There is elevated fibrinogen and CRP, the bacterial aggregation. Next, moving on to periodontal disease and diabetes. It is one of the severe form. Because of poor metabolic control, the complications of the diabetes are triggered because of periodontitis. However, periodontal treatment is beneficial at levels. There is altered wound healing, accumulation of advanced glycated end proteins, altered host response. There is hyperresponsive monocyte or macrophage, lipopolysaccharides and pro-inflammatory mediators are released. However, the P. gingivalis is which causes release of tumor necrosis factor alpha, PGE2 and beta. So the gram-negative periodontal infection causes increased insulin resistance and worsens the glycemic control. However, periodontal treatment causes decreased inflammation, improves insulin sensitivity and glycemic control. Moving on to periodontal disease and pregnancy outcome. The maternal infection can cause release of PGE2 which induces the labor. The fetal membrane is triggered by phospholipase A2. The main bacterial sources of phospholipase initiates the labor. The following categories have been defined by the World Health Organization. Low birth weight and it is less than 2.5 kg. Very low birth weight 1.5 kg and extremely low birth weight 1 kg. The prematurity occurs less than 37 weeks of gestation and very prematurity occurs gestation. So the potential role in an experimental study done in a golden hamster, they found out that there was an establishment of a non-disseminating subcutaneous tissue infection with P. gingivalis or intravenous injection of lipopolysaccharides from P. gingivalis. Fetal weights were significantly lower in the experimental animals and the severity of the fetal effects was directly related to the levels of PGE2 and tumor necrosis. Hoffenbacher was another study. 93 patients, he found out that there was preterm low birth weight babies when there was a periodontitis infection associated with clinical attachment. Translocation of periodontal pathogens to the fetoplacental unit. Action of periodontal reservoir of lipopolysaccharides on the fetoplacental unit. The action of a periodontal reservoir of inflammatory mediators, interleukin 1, interleukin 6, tumor necrosis factor alpha and PGE2 on the unit. The Fusobacterium nucleatum is also plays an important role. The IgM directed against the Fusobacterium nucleatum affects the fetal cord blood of preterm low birth weight samples than IgM directed against other bacteria. So in the cases of preterm low birth weight mothers, we can see high frequency of Fusobacterium nucleatum. There is an hematogenous oral infection. infection. So the interleukin 1, interleukin 6 and tumor necrosis factor alpha stimulates the PGE2 synthesis by human placenta and chorioamnion, which leads to preterm low birth weight. Cross-human fetal membranes, which chronic periodontitis, which influence the fetoplacental unit and contribute to weight. So to summarize, the bacterial infection, bacteria and its products are released in amnion, inflammatory response with cytokine production in amnion, increased amniotic prostaglandin production, that labor. Next, moving on to periodontal and respiratory diseases. The aspiration of oral pathogens, periodontal disease associated enzymes in the saliva may modify mucosal surfaces to promote adhesion and colonization by respiratory pathogens. The periodontal disease associated enzymes may destroy the salivary pellicles on pathogenic bacteria. The cytokines can alter to promote infection. The Streptococcus pneumonia, Streptococcus pyogenes, Mycoplasma pneumonia and H. influenza can colonize the oropharynx and can be aspirated through the lower airways. The normal oroflora, including Aggregatibacter, Actinomycetum comitans and anaerobes such as P. gingivalis and Fusobacterium species can be aspirated in the lower airways to treat. So what is the treatment? Selective digestive decontamination, maintenance of good oral hygiene and prescription of mouthwashes can prevent the disease to a certain extent. Thank you.